Hello, and thank you for joining us today. My name is Logan Savage, and I'll be your moderator for this webinar hosted by Applied BioCode. Today's session is titled Reducing Denials in Multiplex Testing, Navigated Molecular Diagnostics and Broader Payer Policy Requirements. We know that reimbursement challenges are one of the biggest operational hurdles labs face when running multiplex molecular panels, and today we're going to give you practical tools to address that head on. At this time, it is my pleasure to introduce our speaker today. Anne Lambrix serves as Executive Director of RCM Consulting at Lighthouse Lab Services, where she heads up the division's day-to-day operations. Anne brings more than 23 years of experience in medical insurance and billing, giving her a deep and nuanced understanding of the revenue cycle management and the evolving payer trends that impact reimbursement. She also holds a Master of Science in Jurisprudence in Health and Hospital Law. Joining Anne are Parisa Nachi and Ashni Sandani from Applied BioCode, who'll be available to answer any questions. Anne, thank you for being here. The floor is yours.
Thanks, Logan. Hi, everybody. Welcome to today's webinar. I'm really excited to talk to you all about this very important topic, very timely topic, the current payer landscape for infectious disease testing, and how do we navigate this when we're billing and trying to get reimbursed for our tests. So let's talk about the current reimbursement landscape for molecular multiplex testing. So I always like to kind of go through a little bit of a history. Multiplex testing is not brand new. It has, evolved over a matter of, the last 15, 20 years. However, we saw a big spike in multiplex testing, infectious disease testing during the pandemic. So with COVID, seeing a multiplex tests were developed using the PCR methodology. A lot of labs began using this technology. And so with that, we see more tests, more utilization, and then with that comes more payer policy, more scrutiny into coverage and reimbursement. So I always advise when we're speaking with our clients, I advise, the science is well ahead, typically at least 5 to 10 years ahead of the payers. And so labs have developed these great tests. They're able to quickly identify, the patient's illness. They're able to, provide that information back to the ordering physician to better care for the patient. We're all very excited about the testing, the technology that this testing provides. But what happens with that, again, as I've mentioned, is payers struggle developing policy. With multiplex testing, the other challenge is the coding as well. And so we're going to kind of talk a little bit about why there's been such a struggle between the billing, the coding, and then on the back end, the reimbursement and the coverage. Why have we seen this kind of misunderstanding from payers when we're looking to align what is being tested with the payer's coverage? So again, there's all of these things that are happening. Really has rapidly increased during the pandemic. And so now that the pandemic is over and labs are continuing to utilize this multiplex panel, the testing, again, what we're seeing now is payers are starting to develop more scrutiny and more policy behind how they want to cover and reimburse for these tests. What we're seeing with that is a heavier denial and audit process now with the payers. So what used to be, again, considered, payable, I'm sure, again, labs that have been doing this for many years, you can say like we were getting paid, we weren't having issues, and all of a sudden we're starting to see denials, or we're starting to see letters from payers requesting documentation or requesting recoupment back from previously paid claims. So we're seeing that now. We're seeing that in full force now. And so we're also seeing, again, increased development of coverage, so policy. So we're going to talk a little bit about MolDx, and again, what other payers are doing to develop policy and coverage implications for this type of testing. And really, again, this all goes into, if we want to think about the why, it's because of, although it's not new testing, we've seen an increased utilization of this type of testing. And so because payers have not had a broad coverage policy developed yet, That's what's happening now. They're starting to do so. And in turn, that's increasing again, the denials and the audits that are taking place. So right now, we're in a period of, it's a state of flux, so to speak. So we've got, and I'm gonna, before I move on to the multiplex molecular panel testing and the chapter 2, so to speak, I want to talk a little bit about the state of flux and again, the current landscape. The country, we have for Medicare, for governmental plans, if we think about Medicare, there's 7 MACs, the Medicare administrative contractors that operate for the various jurisdictions and process and manage the claims administration and coverage, the LCD for those jurisdictions. There's 7 MACs in the US. Out of those 7 MACs, 4 of those MACs participate in what is called MolDx, the molecular diagnostic exchange, and we're going to go into that a little bit further. And there's 3 MACs that do not. So the 4 MACs that participate are CGS, Palmetto, and Noridian. There are our MolDx MACs. And then Novitas, First Coast, and NGS are the non-MolDx. So that's Medicare. Then you have each state has their own individual policy coverage policies or implications for testing, and that's administered by the state, or depending on the state, they may also outsource to managed plans, and those managed plans may create their own policy coverage determinations. And then there's the commercial payers. So again, in the US, it would be really nice if we had one policy that, one size fits all, that we could say, okay, this is what you need to do. This is how you code it. This is how you bill for it. This is how you're going to get paid with these particular diagnosis codes. These are the parameters, but that's not how we work. We like to make things very interesting here. And so there's all kinds of different policies that we need to be understanding of when we're thinking about billing and looking to get reimbursed for these tests. So the way I think about multiplex molecular panel testing, we've got where we're detecting multiple pathogens from a single specimen. So again, arguably, we're getting a detected, not detected on each individual pathogen. So we could say they're kind of like little tests all in one. But there's there's respiratory, GI, UTI, wound, and STI. Where there is some conflict right now is really with the UTI, wound, and STI panels, where CPT does not have a bundled code. Actually, there is a code now for STI, so I'm going to go back on that. But respiratory and GI, there is a specific code depending on the number of pathogens that you are testing for. So with respiratory, the range is 87631 to 87633. And those are depending on, again, the number of pathogenic targets that you're testing for, that you're resulting, 3 to 5, 6 to 11, and then 12 and 12 plus. And so that's respiratory. And then GI also have a bundled range, 87505 to 87507. And again, dependent on the number of pathogenic targets that you're testing for, you would code appropriately. Where UTI, wound, and STI differ, UTI, wound, there is no specific bundled code or specific CPT code for particular pathogenic targets you're testing for. And so there's been some conflict with how do we code this? How do we bill for it? And so again, there's some disconnect between AMA CPT coding and so what Medicare deems is the correct way to code it versus an AMA guidance. There's also, again, when we're looking at coverage, there's typically clear coverage guidance for respiratory and GI panels, whereas the UTI, wound, and STI limited coverage or very ambiguous coverage information. It may mention within an LCD UTI, but when it looks at specific CPT codes or, again, coverage criteria, when we get into ICD-10 codes, there isn't really any language that supports what will the payer reimburse for in many of the payers. So again, there's a lot of confusion, disconnect, and thus challenge when it comes to billing and collecting on these different types of panels. I'm just looking at the notes here for bundled versus non-bundled testing methodology, again, going back to the respiratory and the GI panels, or even the STI code that's for chlamydia, gonorrhea, and trichomonas. We have to be very careful if there's a specific CPT code for the number of targets. We don't unbundle that. We don't bundle each individual pathogenic target. We bill for the panel code. And it's really important when we're billing, again, what the payer, so Medicare, for example, may pay those individual targets because those individual targets are separately billable and payable. But when running as a panel, the payer is looking for you to bill that appropriately under a panel code. And so even if you're getting paid when billing those individual targets, just keep in mind Medicare is what's called a pay and chase payer, meaning just because you get paid doesn't mean they paid it correctly. So you do risk them coming back, auditing, seeing that you're running it as a panel, you billed incorrectly and you unbundled the panel, and therefore a risk of clawback. All right, so let's get into MolDx. Back in 2022, I believe it was around April of 2022, March or April, the infectious disease testing for those four MACs that participate in MolDx, they rolled infectious disease into the MolDx program. And so for Noridian, CGS, and Palmetto, those four MACs, any lab that is billing those MACs and billing for infectious disease will need to follow the MolDx, the LCD, and article guidance when it comes to infectious disease testing. So what's really important to understand with MolDx is that you will be required to get a Z code. So a Z code, in so many words, it's a Z. It identifies the lab that is performing the test and the test itself. So going back to multiplex testing and why coverage, coding and coverage, right now we're in this state of flux. The amount of tests that are coming out, we've got the LDTs that come out, and there's not enough CPT codes to sign specifically what that test is. So when we talk about a CPT code, it will define a particular organism. It may define a particular procedure, but it does not define the particular test. In many cases, it does not define the particular test that the lab is running. And so there is a disconnect between what the lab is billing for. They're using a CPT code. Let's say they're using an unlisted code, but that unlisted code doesn't pull back to the specific test that the lab is performing and whether or not that test meets clinical validity, analytical validity, clinical utility, checks all the boxes that this is a test we want to pay for. So the Z code goes with the CPT code, and it's almost like I kind of look at it as a little bit of like a prior auth code. It's a code that says this test is being run by this lab and it's for this particular test, this ABC test, which it does this, and that. This is what the lab is billing for. And so the Z code identifies the test and the lab. If the test is not FDA approved, most likely then that test will require what's called a technical assessment. And the technical assessment is really the nuts and bolts of the coverage and the approval process of the Z code. The Z code is just an identifier. If you get requested to complete a technical assessment, that's the important piece to follow through on and get covered, because once it's covered, then again, Medicare knows it's blessed and they will pay for it, depending on, again, the particular circumstances. So again, if you fall within those four MACs, you will be required, most likely, depending on your test. You need to look at the LCD and the article guidance, but you will be required to obtain a unique Z code and perhaps even go through the technical assessment process. And we have those, before I move on to this, we have the three non-MolDx MACs. So if I'm not part of MolDx, and I'm in Novitas, First Coast, and NGS, and what do I do? So this is, again, the challenge right now that we're seeing with, we have very strict policy over here, and then very limited policy or no policy at all over here. And so those labs that have been operating without no policy, unfortunately, because of no policy, and I mentioned the pay and chase mentality of Medicare, despite no policy, Medicare can cite, or the MAC can cite reasonable and necessary guidelines. And what we see now is that the payer, so for example, Novitas is starting to really clamp down on the labs that are billing for infectious disease and having much tighter scrutiny. They're denying, they're requesting documentation, they're perhaps even clawing back because they don't, just because they paid it doesn't mean they've wanted to pay for it. So as we see increased frequency, we've increased utilization, the MACs are starting to say, wait, we need to put more framework, more policy around it. So that is what we're seeing in the Novitas, First Coast, and NGS. Unfortunately, or fortunately, the way you look at it, absence of policy doesn't give us just the green light, thumbs up. There's still going to be some sort of framework. And unfortunately, a lot of the times it's after the fact when a payer comes in and starts looking. And so, again, I'm always an advocate for policy because then at least it gives us guidance on what we should do and do correctly in order to not only get paid, but protect that payment. So going into commercial payer policy trends, commercial payers, this is wrong. They do follow. So United Healthcare and Humana, they have subscribed. So they said, you know what, in our own policy, we're going to say, you're going to need to get a Z code. You're going to need to go through the technical assessment. We're going to participate with what's called the diagnostic exchange. So the diagnostic exchange is MolDx's registry. It's where we register the test and get the Z code. So United Healthcare, for their commercial policy, their commercial plan, will require, they do require some of the MolDx. Now, again, the CPT codes where they want the Z code, it's getting into the they want the CPT code for your respiratory, your GI, 87801. Those are all going to fall under the MolDx or their UHC policy requiring the Z code. We're seeing more payers require prior auth for infectious disease. You know, when we look at unit and target restrictions, I think it's important to understand there is what's called MUEs, medically unlikely edits. We are seeing more, even if there's a published MUE, more payers restricting the number of units to less than the published MUE and requiring documentation and appealing in order to get paid above the MUE or their unpublished MUE. As I mentioned before, you've got a myriad of payers and there is inconsistencies. So just because you have coverage by this very, small region-specific plan doesn't mean that there's broad payer coverage for that test. It's very important to really understand coverage, I think, for the big five. The small regional plans may have adopted coverage or they just haven't gotten around to having coverage or a specific policy. So it's important to be thinking about that. And then, what we've seen is where we have specific payer-specific workflows adopted by billing in order to identify upfront, again, policy where if they will pay for specific panels or for targets, based on a patient's diagnosis code, place of service, et cetera, it's flagged on the front end before the claim gets all the way to the payer, whether or not it's going to meet that payer-specific criteria. What we do, so we're a consulting group that works within Lighthouse Lab Services. Lighthouse is, it sets up labs. We build out the lab, so to speak. And my team really helps provide visibility into that reimbursement piece, which a lot of times, as I mentioned in the very beginning, we're not even thinking about simply because we have this great test. And it's like, Everybody needs this. It's great. It's going to save a lot of time, a lot of money. Let's get it going. And so a lab will start billing and then they contact us because they're not getting paid. So what we do is we call it a payer analysis and we look at, again, we get the lab's, payer mix, look at their top 5 payers. We always look at Medicare and we look at the Medicare LCD. Want to make sure we understand what MAC are we billing to and what kind of, really Medicare, kind of the gold standard when it comes to policy. What are we going to need to start thinking about when it comes to this test? And so we look at coverage criteria for each one of those plans and we determine whether or not there's existing policy or specific language that again will say, I cover this test in these circumstances. And so that's when we talk about billing out payer specific workflows and upfront and front end workflow where we're loading up, ICD-10 codes, we're loading up CPT codes where again, if that comes through without the appropriate information, right away it's not going to get covered. All right, so as I mentioned, we do see where an increase of denials and requests for documentation, just more payer scrutiny when it comes to multiplex infectious disease testing. And these are kind of the top drivers. And so let's go through each one of these. And I'll talk a little bit about lack of medical necessity documentation. So I really always go back to when we think about infectious disease and what we're seeing with the payers and again some disconnect between the AMA CPT coding and the NCCI guidelines and making sure we're billing with the appropriate code, and if there is a lack of code, what do we do? And when it comes down to this, folks, in my opinion, this issue is not a coding issue per se. This is a medical necessity and what the payer deems for these tests, what they deem appropriate coverage when they will cover these specific tests and the medical necessity criteria. So if the payer comes in and says, okay, lab ABC for Ann Lambrix, you ran a UTI panel, we'd like to see the documentation. So the lab submits the requisition, the results, maybe some notes from the ordering, but the ordering doesn't, there's no clear criteria of why that UTI panel, that PCR test was ordered. It gives the payer fuel to say, well, wait, you know, we paid for this test or we're not going to pay for this test because we don't really see that there's documented medical necessity. So we see that very often where there's not clear notes within the patient chart of where the test will impact the patient care, the overall outcome, right? And so the lab really isn't responsible for deeming medical necessity. So we can have another webinar about that. But really, the lab, you're kind of put in the middle. And so it is important to be thinking about if you cannot get that good medical necessity, you're going to be put at risk. If you can't get that clear documentation, you'll be put at risk for a denial or a recoupment. And so it is helpful to be able to educate your ordering as far as this test. Again, there has to be clear indication within the notes of why the test was ordered and what was the outcome. Overutilization we've talked about, and this is really, in my opinion, why we're seeing such a influx of denials and recoupments. We saw extreme spike. If you look at the Medicare report, which I think from 2025, their spend report, 87798, there's several codes that we would see labs bill for multiplex testing. They really spiked. Their spend spiked. And that's how payers identify. They're getting better though, right? They've got AI, just like we're trying to use AI in the front end. These payers are using AI in the back end to identify utilization trends, overutilization trends. And what they do is they flag over to utilization and then they're saying, I want documentation to support. There's that snowball effect. Incorrect CPT coding or unit reporting. It's really important, especially if you're within the MolDx Act, to really understand the correct coding. If you're a non-MolDx Max, there is still, again, arguably between AMA and NCCI, but the response from payers has been unanimous. When I speak with payers, I speak with clients, what they're hearing from payers is what they're looking at, folks, is one test equals one code. So we really have to be able to argue that this was not one test, it's multiple tests. And I point back to what is the physician ordering? Are they ordering a panel? Are they ordering each individual pathogenic target? So I want you to think about that. Diagnosis to task mismatches, I think that's pretty self-explanatory. And again, if there's clear policy, MolDx has clear policy on the specific panels and what diagnosis codes, the ICD-10 codes, the groups that will be considered medically necessary. Novitas, First Coast, I believe NGS, but I know for sure Novitas and First Coast also have LCDs in place for GI and respiratory. So you want to really look at that article guidance to look at what the payer, so not just Medicare, but your insurance, your commercial plans, what are they, when they look at the patient diagnosis code, the procedure, the CPT code tells us what's being performed. The diagnosis code tells us why. And so we really want to align that diagnosis code with, are they going to cover this test? If Anne has, if she has a sniffle, are they going to cover for it? Frequency edits and duplicate testing. We talked a lot about the frequency, overutilization, and MUEs. And then missing or inconsistent ordering documentation. I think that can go back to step, the first one. Documentation. I see all the time silly things like lack of signed order. The payers are getting us on that. Make sure you have a signed order, or again, then the ordering physician has to put intent to order within their notes if there is no signed order. Sometimes the denials are silly, and we can get them overturned by providing good information back to them. And so where I see a lot of times labs fail is not because they don't have the information or because they're unwilling to provide the information. It's failure to respond to the request, or sending it's sloppy. They're sending in incomplete information. So we do that, we put a big red flag on our backs. All right, so documentation requirements. And I will tell you, like, a little disclaimer, this isn't a be all end all, and you can send in all of these things and still have to continue to fight. But this is just generally what the payer would be looking for. And again, really, you need to tie back to that patient and their individual insurance, what their coverage is. So if the payer says, I will only cover this in these circumstances, you can send all this kind of documentation. It's not going to result in an overturn, most likely. All right, so we talked a lot about the coding and billing, and so this is a slide just kind of, again, reiterating the appropriate coding. So making sure that if there is a specific code for your test, so with GI and respiratory, even STI has a code for chlamydia, gonorrhea, and trichomonas. It's a bundled code, that you're not unbundling and billing each individual target. So for example, 87631 to 87633, you can see where it depends on the number of targets you're testing for. Another thing that I have seen labs starting to get in trouble for is downcoding. So let's say you're running an 87633, so you have 12 plus targets in your panel, and the payer only pays for 3 to 5 targets, the 87631. I've seen labs where they will bill for the 87631 and, it passes edits. What they end up in trouble with is, again, if the payer sees overutilization, or they are just really right now targeting infectious disease, coming in, auditing, and saying, well, you are billing incorrectly. You're not billing for the test that you performed. So again, be very cautious if you are practicing the downcoding methodology. 87798. I've seen this code again. It's in the I would say been significantly flagged by not just Medicare, but other insurance plans. We're using that code for infectious agent detection, not otherwise specified, for panels such as UTI and wound, where there is no bundled code like we see with the respiratory and GI. That is starting to close, folks, where the payers, again, going back to the language where it says one test equals one code. So what they're looking and pushing towards is 87801. We would argue that we don't think that's the appropriate code to use. However, that is where a lot of payers, including the non-MolDx MACs, are pushing labs towards. So it's really important as you look at your panel, having a certified coder. So on my team, we have certified coders that they specialize in lab and pathology. So this is what they do all day. And so having a coder that really understands this very niche part of the health industry help you with your coding and making sure that there's some good understanding of what you're doing, and that we can support the codes that are being submitted. All right, so reducing denials before submission. I think it's really important, again, to ensure that you understand with the patients that you see. Not only are you verifying their eligibility for coverage, and eligibility for coverage, just because you have a contract with the payer, doesn't mean that test will be covered. So when we talked about a little bit about reviewing on the front end by the different insurance plans that you see, are those patients that you're getting ordered that are coming through your lab, are they eligible for coverage? And, again, are they United Healthcare? Are they going to require a Z code? Are they, is there specific guidance on the type of testing that will be considered medically necessary? We've got, a smaller panel versus expanded panel, and really understanding that eligibility and whether or not the payer requires any sort of prior auth. So prior auth, I kind of bucket into the MolDx, the Z code, even though that is not a prior auth. I want to be clear. I just, that's more of a front end review of, does this payer require anything up front or on the claim in order for me to submit a claim and get paid? Claim scrubbing and policy monitoring, again, I think we can think of them as a little bit of one and the same. We want to make sure that we have current up-to-date policy and that we're making sure we understand when we submit a claim, do we have all the appropriate fields completed? And do we understand, again, payer policy on what we're submitting, whether or not, again, there should be appropriate coverage or not? I mentioned about appeals, audit preparedness, and denial recovery. I think really what I want to emphasize is, number one, there should be a mechanism within your system, your lab, to respond to any audit or documentation requests. As I mentioned, oftentimes these get put on someone's desk, never responded to, and so it's a snowball effect. If we don't respond, even though you are operating in good faith and applying as much as possible best practices, you understand policy. If a payer comes in and asks for documentation, it is within their rights to do so. And if you fail to provide, it's 100% failure. And again, you really run the risk of any additional audits that take place. You're already under higher scrutiny. So make sure you have a way to capture those that communication from insurance plans. And then don't just submit, don't be sloppy in any appeal. If you're getting requests and you can support medical necessity, you have the right documentation, you've checked all the boxes, we have a great test and this should be covered. Let's build a policy aligned appeal letter and making sure that you are checking all the boxes for that payer requirement and you're sending in a robust appeal. Don't be sloppy. They don't typically have, there's not an Lambrix looking at every appeal. It's usually bots or looking for, specific language. So really understand what you're appealing and make sure the team that's doing the appeal is again checking the box to support that medical necessity and the clinical criteria for payment. And pay attention to your denials. I always say, like I joke around, I have a Nancy Drew hat that I put on. Your denials can be a really good clue to issues with payers and a precursor of potential issues that you need to address on the front end. So if you're billing a specific CPT code and you're constantly getting denials for not medically necessary, that's a red flag, folks. There's a policy out there. And so you really need to uncover that. Don't just keep billing it. And really, you shouldn't just downcode. You need to address the policies and make sure that on the front end, you are compliantly billing and managing the payer requirements. And that will also prepare you for audits and clawbacks, right? So if you have, I just spoke with an attorney and we talked about getting your house in order. So it's really hard to argue back to a payer and to say they should have paid something or they should pay for something when your house is not in order and you can't support, you don't have good information, or you're not responding to requests for information timely. All right, we talked about this. I know I'm running out of time and I want to save time for questions, but I do think it's really important. Just continuing to reiterate, making sure that when you have a test, for your molecular and genetic testing, so multiplex testing, what I would consider like non-core labs, really understand your payer mix and coverage criteria and making sure that there is a good workflow within your system to address the policy and to make sure you're monitoring your denials and any impacts regularly. And then making sure you're educating your team. That's another thing. We can have all the policies in place. We can have a great system. But if your billing and your follow-up team aren't part of that conversation, it's for naught, right? And then I'm a big fan of KPIs. And so setting up and making sure you're managing your KPIs. There is a famous quote, what is measured gets managed, or what is managed gets measured. But making sure you're managing your billing and your collections and you really have good visibility into what's happening will help you address and ensure, again, that house is in order. You'll help you address any sort of trends that are being identified on the back end. You can fix it on the front end. All right. I'm going to quickly closing remarks. I think, one of the things that I didn't touch on in this, but really quick, I'm going to touch on is the Medicare LCD for infectious disease that really specifically talks about expanded panels. And expanded panels are greater than 5 targets, right? And so again, when you're looking at these larger panels, there's very specific coverage criteria with most insurance plans. There may be small MONPA regional plans that will pay for large panels, but really pretty much across the spectrum, there is very limited coverage for expanded panels. So the smaller panels, and that's what, again, I advise and I want us to be thinking about, really what the payers are looking for is more a patient-centric approach, meaning when a patient comes in with certain conditions, they may not qualify for a panel and or an expanded panel, okay? And so as we continue to see development of coverage, as we continue to see development of CPT codes, labs that are really thinking about the patient-centric approach and developing their panels to more specific targets, I think will be in a better place once policy continues to develop. But thanks everybody for the time today, and I think we can go ahead and open it up for questions.
Yeah, thank you so much, Anne, for that really thorough and practical walkthrough. We really appreciate all your expertise and all that you've shared today. So we do have some questions that have come in, and I'll just put it out there for everyone else. If you think of anything as we go into questions, please continue to submit questions using the Q&A panel. So the first question is talking about respiratory versus GI multiplex panels. So how are these two treated differently under the LCD?
So there is an LCD. I'm going to reference it's 39001. And so respiratory, I think they're similar in structure. So again, if you look at we talked a lot about the CPT coding, and so 3 to 5 targets tend to be more favorable coverage. When we look at expanded, if this panel is smaller and targeted, which is, the less than 5 targets, expanded 6 or more pathogens, they're going to require better justification. So respiratory, I think the LCD is really going to focus on whether the broad testing is necessary based on respiratory severity, underlying pulmonary disease, the immunocompromised status. You're going to need a specialist involvement, and whether the result would change treatment decisions such as antibiotics, antivirals, isolation, or escalation of care. GI is really whether the patient has a clinical presentation where identifying a pathogen will change management. And again, we got to think about when we submit a claim, you're submitting a CPT code and a diagnosis code. So how are they going to find out if it's changing management? The documentation, right? So GI panels, we really need to identify where that testing for that specific pathogen is going to change management. So example, if there's significant diarrhea, concern for infectious gastroenteritis, immunocompromised status, outbreak, public health relevance, or severe prolonged symptoms. We, for both, I think, avoid broad respiratory or GI testing when the result isn't going to alter treatment or when the presentation is mild or self-limited. I did do like a heat map based on that LCD and pulled the article guidance and really looked at the diagnosis codes to determine, whether or not routine care scenarios where these expanded panels, so again, expanded panels defined as greater than 5 targets, whether or not in various scenarios the patient would be eligible. So routine care, respiratory GI, patients not eligible for coverage. If it's syndrome specific, respiratory not eligible, GI limited, high acuity patients, so immunocompromised, ICU, severe disease, those two, respiratory and GI, there's a high probability of coverage.
Thank you. That leads nicely into another question that we had that's specific to LCD 39001. So, how does the patient setting, inpatient versus outpatient, affect Medicare coverage specifically and decisions under LCDs?
I think it's important to understand like outpatient setting, this LCD is specific for outpatient. So an outpatient setting, we bill Medicare Part B, and that's what this policy, the 39001, is covering outpatient. And so really looking at the criteria for coverage and the specialist, the patient indication is important. But in an inpatient setting, there's different Medicare pays, like for example, inpatient, it's paid through what's called a DRG. So it's a bundled payment, and those tests will be included in the diagnosis related grouping, the DRG. And so there is coverage, but again, labs need to understand it's separately paid to the hospital. It's bundled into the hospital. If you're an independent lab serving, inpatient, doing inpatient patients, that payment, you'd have to seek that payment from the hospital. So
Okay,
it's different payment
okay.
structure.
Okay, thank you. So, more specific here, and in this example, will a claim be denied if the lab blocks 2 targets in a panel capable of detecting 12 targets, provided that the 2 blocked targets are the ones not being reported?
So I would like so you need to bill with what is being ordered and resulted. All right. So if we're ordering, it sounds like 2 targets or 4. So this is one of those things like I think I would be more than happy to delve into further, but you can mask results. However, it's very, 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 very important that you result what is ordered. You can't mask that. You have to result that. And so if you're resulting what is ordered, and I go back to what are you billing for? And if the payer requests documentation. So what you're billing for has to match what was ordered and resulted. So hopefully that answers that question. But again, happy offline to talk through that.
Thank you. Okay, a broader question here. So, what emerging legal or regulatory developments could affect multiplex panel reimbursement in the next 1 to 2 years? What do you see on the horizon?
Regulatory, I do feel like, so just last week, the ex-medical director, Dr. Gabe Van Wilner, did announce his resignation. He's going to be staying with MolDx for some time as a consultant, but I'm still trying to figure out what that means for the program. I really feel that there has been, again, in the non-MolDx Max, there has been significant, I don't know, I shouldn't say significant. There's been an influx of denials and recoupments because of lack of policy. So I do see that we're kind of ripe for more policy, more structure. And so it wouldn't surprise me if we see more Macs roll into the MolDX program, or if they don't, be very structured and maybe even, introduce additional LCD or introduce more policy regarding infectious disease. So I do feel like the MolDX program is strong. We'll probably, even with Dr. Van Wilner leaving, I wouldn't be surprised if more Max and or more commercial plans roll into it. There's also just something we haven't talked about, and it really, like, this is relevant for all of the clinical lab, but PAMA and the CLFS reporting. For all that is not aware, the PAMA regulation, which has been pushed and postponed for like 5 years, this year, starting, I believe, this month, you are required, if you had billed last year, so the reporting period is January through June 30th of 2025, and you're required to report your private payer data by July 31st of this year. So the way that they set the clinical lab fee schedule is by taking an average of, and this is a very, very rough explanation of PAMA and the clinical lab fee schedule, but they take the labs will need to report their private payer data, and then Medicare takes it and they get an aggregate of how much each test was paid, and Medicare wants to be the lowest payer. So that's how they set their fee schedule. So we are looking at significant rate adjustments, again, starting, I believe, not this year, probably 2027, where we will see some rate adjustments. So I think that's something to be considering when getting paid off of the clinical lab fee schedule, either with Medicare or any managed plans that tie their fee schedule to Medicare. And then the only other thing that I can think of from a regulatory standpoint is just the FDA oversight of LDTs. And although it was rescinded, it kind of, went away, which we were all excited. I do think that because of that, and again, the amount of LDTs out there, payers are wanting to have better scrutiny, better control over laboratory developed tests. So even though the FDA oversight went away, it's still lingering, and it really will linger in more policy, more scrutiny surrounding LDTs.
All right, thank you. I think we have time for this one more question. It's a bit long, so hang with me. So,
Okay.
we clearly see that MACs are expanding their activities, including the safety and efficacy determinations, on top of the reasonable and necessary assessment. With that, MACs are acting more and more as compliance regulators like the FDA. The latest announcement by FDA and CMS on the new RAPID program drives a paradigm shift with the companies to start including reimbursement and payment evidence creation from the start. This impacts development costs and timelines, and in the end, access to new testing for patients. What is your view on these new developments, and will MACs be able to keep up with the industry?
So rapid, my answer is no. I don't think they are able to keep up with the industry. These policies, these introduction of law, they are proposed fixes to a big problem, but there's always, there's argument, and it just like it doesn't end up being a major priority for the country to pass. And so it ends up being, again, the payers are left to their own devices and very little oversight for how they develop tests and reimburse for tests, or develop policy and reimburse. So what was the last part of that question, please?
Will
Alicia? That's okay.
MACs be able to keep up with the industry? It's the last piece of it.
No, I think again, unless they introduce, more oversight for Macs to adapt to the evolving landscape with testing and have a timeline, to require them within so many days and again, I think that's part of the policy is that they've got to approve, the LCD process is supposed to be faster. But again, this sounds very like pessimistic, but I'll believe it when I see it. It sounds really negative. It's just like there's trying to deal with government plans. It's just as I'm sure everyone is in agreement. It's slow and cumbersome. Takes a really long time to change.
All right. Well, that is all the time we have for questions today. If we were not able to get to yours, we'll follow up with you via email. For more information about Applied BioCode and their high throughput multiplex molecular diagnostic panels, visit apbiocode.com or reach out directly to the team to request a demo. Stay tuned for more upcoming webinars and be sure to subscribe to Applied BioCode's updates to stay current on the latest in molecular diagnostics and reimbursement guidance. Thank you again to Anne and the entire team at Lighthouse Lab Services, to Parissa and Ashni at Applied BioCode, and thank you all for attending today. Take care, everyone. Goodbye.
Thank you. Bye-bye.